The first, acute glomerulonephritis or acute nephritic syndrome, or the synonym is also post-infectious glomerulonephritis, is acute diffuse inflammation in the glomeruli associated with hematuria. Hematuria means red blood cells in urine, casts in urine, sediment, proteinuria, and often hypertension, edema, and azotemia. Etiology of acute glomerulonephritis is acute infectious disease such as tonsillitis, scarlet fever, acute respiratory diseases, for example pneumonia or otitis, especially caused by hemolytic streptococcus group A. More rare by pneumococcus and staphylococcus and some other infections. And risk factors or predisposition factors may be overcooling, especially in damp weather. Pathogenesis. Acute glomerulonephritis typically arises not during an infectious disease, but only following a period, usually 2 or 3 weeks later. Thus, the onset of acute nephritis usually coincides with the period when antibodies to streptococcus are produced. The antigen-antibody complexes are fixed in the endothelial and epithelial cells of the renal glomeruli and also in the basal membrane of the glomerular capillaries to cause the injury. Both kidneys are always involved in acute diffuse glomerulonephritis, and all glomeruli are equally affected. So the etiology and pathogenesis is the similar as etiology and pathogenesis of acute rheumatic fever, if you remember about acute rheumatic fever. Clinical picture. The disease is most common in children and in young adults, but 5% of patients are more than 50 years old. A latency period of 1 to 6 weeks, average 2 weeks, occurs between the infection and the onset of acute glomerulonephritis. The clinical picture of acute glomerulonephritis is quite specific and is determined by the main 3 syndromes: edema syndrome, arterial hypertension syndrome, and changes in urine, such as hematuria and proteinuria. Hematuria means red blood cells in urine, proteinuria means protein in urine. Complaints of the patients. The patients would usually complain of edema, which arises first of the face, under the eyes, and then extend into the entire body and the extremities. Headache and heaviness in the head are frequent symptoms. Vision can be deranged due to spasm of retinal vessels and hemorrhages into the retina as a complaint of high blood pressure. Many patients complain of general fatigue and reduced work capacity. In the presence of pronounced edema and massive pleural effusion, and when the heart muscle is overloaded due to markedly increased arterial pressure, patients with acute nephritis suffer from severe dyspnoea, sometimes with attacks of asphyxia like in cardiac asthma. The patients with acute nephritis would often complain of dull lumbar region. The gravity of the disease depends on the degree of oligouria. Oligouria means decreased urine output less than 500 milliliters per day. Complete anuria may occur in some severe cases. Anuria means decreased urine output less than 100 milliliters per day or complete absence of urine. If hematuria is marked, the urine looks like mid-waste water. Very useful symptom. Physical findings. Inspection of the patient reveals his specific appearance. Pay attention at this description. Pallid skin, edematous face, swollen eyelids, and edema of the trunk. So pallid skin, edematous face, and swollen eyelids, these symptoms are combined in so-called facies nephritica. Remember this symptom. You've got such a question on exam. Some patients assume the forced semi-reclining or sitting position because of pronounced dyspnoea due to acute left ventricle failure or exudative pericarditis. This forced position is called orthopnoea. This is example of facies nephritica with swollen eyelids, edematous face, and pallid skin. This is checking of edema, leg edema, and traces of the socks. How to check edema? We must press the skin of the patient to the bone, for example, count till 10 for 10 seconds. Then, if you see the forces, if forces are staying, it means that patient has edema. Now we will watch an educational video on practical skills, how to check our patients with kidney disorders. Maybe on arms, maybe on abdominal wall, sacrum, and legs. So how to check edema of this area? To the bone and count till 10 seconds. Then we take off our fingers and there is no forces. If we see forces, it means edema. What about abdominal wall? We must pinch the skin folder, also count to 10 and then see the forces. In this case, forces absent, it means no edema, sacrum. We press tissues to the bone, to the sacrum, and count till 10 from one side and another side. There is no forces, no edema. The same as the legs. So in this case, our patient has no edema. And what about lumbar region? Where is the localization of lumbar region and kidneys? So where left kidney and right kidney? That localization is same or not? Different. Left kidney is upper. And where is left kidney? How to find left kidney?
Like the last thoracic vertebra and from the left kidney.
Not so bad. So we must find 11 thoracic vertebrae and the upper pole of the left kidney will be at the level of 11 thoracic vertebrae. How to find 11 thoracic vertebrae? We find the angle of the scapula, it means the 8 thoracic vertebrae, and count 8, 9, 10, 11.
Mm.
It means that this is the level of the upper pole of the left kidney. And the lower pole of the left kidney is between the first and the second lumbar vertebra. So we count here, and here will be the left kidney. The 12th rib divides left kidney into 2 equal parts, and right kidney 3 centimeters long. So it means that lumbar region here, not here like you showed me, lumbar region here. So we inspect lumbar region. In this case, lumbar region is symmetric. The skin of normal color, because for example, when patient has paranephritis or paranephritic abscess, it may be asymmetric and red, hyperemia and hot on palpation. In this case, symmetric, and the skin is not changed. After this, we may perform perfusion of kidneys. Perfusion means post-vertebral test. Post-vertebral test, we put our palm on the lumbar region and perfute by another palm. If our patient feels pain, this symptom is considered to be positive. It may be two-sided positive or only one-sided positive. Two-sided positive in case of glomerulonephritis, so immunological inflammation of kidneys, and one-sided it may be in case of pyelonephritis, the inflammation of renal pelvis, or carpuli, renal carpuli. Is it clear? Okay, what about palpation? Palpation of kidneys is performed in 2 positions, vertical and horizontal. Why in 2 positions? Because we may diagnose the movable kidney. So normally the kidney is movable only for 2 or 3 centimeters due to inspiration and expiration, due to moving of diaphragm. This is normal. But in some patients, the kidney may be more movable, for example, 5 centimeters, 10 centimeters. So in vertical position, due to gravity, the kidney may go down. And that is why we may palpate it. And if we palpate the patient only in horizontal position, we can't diagnose it. Because in horizontal position, kidney will have a normal localization. There is why in 2 positions, vertical and horizontal. Normally in adult person, we can't palpate kidney, we can't feel it. We palpate, but we can't feel it due to its deep localization. If we palpate the kidney, it means that it is movable or enlarged. It may be enlarged due to tumor or due to polycystosis. Is it clear? Yes. So the technique of kidney palpation. No. We stand at the right side of the patient, ask the patient to put his arm to the shoulder. Then one hand we put on the lumbar region, another hand we find the cross of right costal arch and right not medical auricular, right side of the musculus rectus abdominis. Put here the hand. The hand must be slightly bended fingers, and ask our patient to inspire and expire. Inspiration, expiration, we deep in, inspiration, expiration, deep in, inspiration, expiration, deep in, a small inspiration, stop, balloting, and traction. Balloting means trying to find the kidney between 2 hands. So this hand is also balloting the hand, the lumbar region. is also belting and traction. While belting, we try to feel the bowl of the kidney. In this case, right kidney is not palpable. This is normal. Left kidney. Left kidney. We put the palm on the left lubricant. No, we make. Find the cross between left costal arch and musculus rectus abdominis, and once again, inspiration, expiration, inspiration, expiration, inspiration, expiration, a small inspiration, belting, and traction. Left kidney also is not palpable. After this, you may lay down your patient, lay down. The position of the patient is the same as the position of the abdomen at the right side of the patient, face to face to the patient. And the technique the same. So we put our hand in the lumbar region, find the close, and ask to inspire, reach, inspiration, expiration, inspiration, expiration, a small inspiration, belting, and traction. Right kidney is not palpable. The left kidney the same. Let me not show you, or you need to show the left the same. Auscultation of kidney, of renal arteries and aorta. So auscultation we may perform at the anterior and from the back. Anterior, the points of auscultation of renal arteries. So we will find the musculus rectus abdominis, right and left, and at the level of the umbilicus here will be the points. Normally we don't hear any murmurs. Only peristalsis. Aorta. Aorta by listening at the epigastric region. Also, any murmurs. This is normal. If we hear any murmurs, it means stenosis. Stenosis may be one-sided, for example, right renal artery, or two-sided. This is very severe disorder. Stenosis may be, for example, due atherosclerosis. If we hear more about aorta, it means stenosis of aorta. For example, also atherosclerosis. And the back side, for example, sit down. Back side. We find vertebral column and we find the 12 rib. And between vertebral column and 12 rib here and here will be 2 points. Also nothing. So no murmurs. This is normal. So this is all for today. Critical skill. So the sound is normal. Do you hear the sound of video?
Yes.
Yes, okay. Have you any questions about inspection of kidneys, costovertebral test?
No.
No. Okay. Let's continue our lecture. Other physical findings. We must perform inspection of the chest of these patients, percussion of the chest in the presence of generalized edema reveals free fluid in the pleural cavity, transudate or hydrothorax, and congestion in the lung root region. So we will detect dull and timpani sound due to compressive atelectasis. Normal or harsh respiration is heard by auscultation, and in the presence of pronounced congestion, dry and moist congestive rales may be heard. Acute nephritis is characterized by a tense arterial pulse, which is sometimes slow. Systolic pressure increases to 200 or even 220 millimeters, but in some cases it is not so high. Diastolic pressure also increases. Apex beat may be shifted to the left and increased due to myocardial hypertrophy, which soon develops in the presence of arterial hypertension. The left body of the heart extends beyond the corresponding midiclavicular line. Auscultation of the heart reveals bradycardia. The first sound is sometimes decreased at the heart apex due to left ventricle hypertrophy. In the heart muscle is much overloaded. The gallop rhythm may be heard. The second sound is usually accentuated over the aorta due to high blood pressure. Laboratory and instrumental examining of patients with acute glomerulonephritis. During development of edema, diuresis usually decreases to oliguria. Urinalysis is characterized by proteinuria and hematuria. If hematuria is pronounced, urine can be reddish brown, the color of meat wastes. Microscopy of the urinary sediment usually reveals the presence of casts, mainly hyaline casts, and cells of renal epithelium. In blood biochemistry, creatinine and urea may be increased, especially in cases of anuria development. And if we calculate glomerular filtration rate may be decreased if patient develops acute renal failure. The infectious allergic character of acute glomerulonephritis is confirmed by immunological shifts. The content of alpha-2 and gamma globulins in the blood increases during the acute period. The antibody titer against the causal infectious agent usually rises within 1 to 2 weeks. The increase in antibodies to streptococcal antigenic products can be measured, such as antistreptolizin O and antistreptide. We have stopped at laboratory and instrumental data and at confirmation of autoimmune or immunological nature of acute glomerulonephritis. So, the infectious allergic character of acute glomerulonephritis is confirmed by immunological shifts. The content of alpha-2 and gamma globulins in blood increases during the acute period. The antibody titer against the causal infectious agent usually rises within 1 or 2 weeks. And we may detect increasing in antibodies to streptococcal antigenic products such as antistreptolizin O, anti-hyaluronidase, and anti-desoxyribonuclease. X-ray. We may perform X-ray of the chest. This study will confirm the presence of pleural effusion and congestion in the lungs. We may also detect dilatation and hypertrophy of the left ventricle. Left ventricle hypertrophy also may be detected by ECG, and we may use ultrasound, abdominal ultrasound, which may help to differentiate acute disease and chronic, and the exacerbation of chronic glomerulonephritis. In case of acute glomerulonephritis, the kidneys will be enlarged in size due to inflammatory edema, and in case of chronic glomerulonephritis, the sizes of kidneys will be decreased to small kidneys. Complications of acute glomerulonephritis are acute left ventricle failure, disorders of cerebral circulation, renal eclampsy, acute renal failure, and nephritic syndrome. Diagnosis of the acute glomerulonephritis is based on main three syndromes: edema, arterial hypertension, and is supported by changes in the urine, hematuria, proteinuria, and casts, a history of sore throat, impetigo or culture-proven streptococcal infection 1 to 6 weeks before onset of the syndrome, and elevated serum titer of anti-streptococcal antibodies aid in diagnosis. So pay attention on this main idea, how to make a diagnosis of acute glomerulonephritis. Next, chronic glomerulonephritis. Chronic glomerulonephritis or chronic nephritic syndrome is a syndrome caused by several diseases of different etiology, characterized pathologically by diffuse inflammation and sclerosis of glomeruli, and clinically by proteinuria, cylindruria, hematuria, usually hypertension, and insidious loss of renal function over years. Etiology is diverse and includes post-infectious diffuse diseases of connective tissue, bacterial endocarditis, and idiopathic. It is often secondary to the acute form of this disease if the patient is not timely and properly treated. Pathogenesis of chronic glomerulonephritis. Antibodies to altered proteins of the renal tissue are probably formed in patients with the disease, in addition to formation of antibodies to streptococcus and other agents. Deposits of immunoglobulins detected by fluorescence microscopy are present in glomeruli. This maintains the inflammatory process in the kidneys and is the cause of chronic progressive course of the disease. Clinical picture of chronic glomerulonephritis. The disease remains asymptomatic for years and is thus undetected in many patients. Two periods can be easily distinguished in the course of the disease. The first period, when the nitrogen secretory function of the kidneys is impaired only insignificantly, the stage of renal compensation, and the second period during which the function is affected substantially, it is called the stage of renal decompensation. For the first clinical manifestations of the stage of renal compensation, clinical manifestations may vary according to guiding syndrome, and the most typical clinical forms of chronic glomerulonephritis are nephrotic, hypertensive, isolated urinary syndrome, mixed, and latent. Clinical forms. For the first nephrotic syndrome, clinical picture of the nephrotic form of chronic glomerulonephritis corresponds to nephrotic syndrome. This syndrome is characterized by edema, urinary syndrome, and comparatively rapid course. So you must revise your knowledge from the previous semester about nephrotic syndrome in order to know the clinical presentation of this form of chronic glomerulonephritis. The next form, hypertensive form, is comparatively benign and is characterized by the hypertensive syndrome and insignificant changes in the urine, such as hematuria and proteinuria. Next form of the isolated urinary syndrome, is discovered only by persistent mild or moderate proteinuria and hematuria accompanied by cylinderuria, hyaline or erythrocyte casts, and either hypostenuria. So from the previous semester, also revise your knowledge about disorders of diuresis. We have talked about oligouria, anuria, hypostenuria, and so on. The next form, the mixed form, is characterized by edema, changes in the urine, and arterial hypertension. This form of glomerulonephritis is the gravest and comparatively rapid. A pronounced renal failure develops into 2-3 years from onset of disease. Finally, there is the latent form of the disease, which is not manifested by edema or pronounced hypertension. The changes in the urine are only insignificant, and renal failure develops at late terms, often only in 10-15 years from onset of the disease. Now, the symptoms of the second or final stage of renal decompensation stage. So renal decompensation develops gradually due to progressive nephrosclerosis. The concentration capacity of kidneys gradually decreases along with the decrease in the specific gravity of the urine. Nocturnal diuresis increases by the compensatory mechanisms as well. It is 2/3, 1/2 of the daily diuresis. This symptom is called nocturia. As the concentration capacity of the kidneys is affected to a great extent, the specific gravity of urine becomes low, and its variations between 1009 and 1011 during the course of the day and under the effect of dry food are insignificant. So this symptom is called either hypostenuria, low specific gravity with low variations of specific gravity during the day is called either hypostenuria. And the last, the content of nitrogenous slags in the blood of patients such as urea, creatinine, indican increases during this period. Symptoms of uremia may develop such as weakness. The patient complains of lassitude, headache, nausea, skin itching, unpleasant ammonia breath, and impaired vision. Not long before death, the patients develop uremic coma. Complications of chronic glomerulonephritis may be nephrosclerosis, uremia, left ventricle failure, retinopathy and cerebrovascular disorders, and anemia. Diagnosis. The disease may be discovered during a routine medical examination when the patient is asymptomatic and renal function is normal, except for proteinuria and possibly hematuria. We need complete blood count for detection of anemia, of course urinalysis, blood biochemistry, calculating of glomerular filtration rate, and before renal function is significantly impaired, biopsy may help. And according to the biopsy, the glomerulonephritis may be divided into two basic groups, non-proliferative and proliferative. Non-proliferative includes minimal change disease, focal segmental glomerular sclerosis, and membranosus nephropathy. Proliferative glomerulonephritis includes immunoglobulin A nephropathy and membranoproliferative glomerulonephritis. Course. Chronic nephritis usually lasts from 3 to 15 years. The first period of the disease, renal compensation, is long. The second period, decompensation, is shorter. During the course of the disease, there occur more or less prolonged periods of exacerbation, which are usually provoked by cooling or infections. Exacerbations are followed by remissions. As a rule, the patient dies of renal failure. That is why we will continue talking about chronic renal failure. So chronic renal failure is the clinical condition resulting from chronic derangement and insufficiency of renal, excretory, and regulatory function. Causes of chronic renal failure are any major cause of renal dysfunction, such as chronic renal diseases, glomerulonephritis and pyelonephritis, diabetes mellitus, arterial hypertension, thrombosis, atherosclerosis, some genetic factors, and so on. So the risk factors of chronic renal failure are presented on this slide. Pathogenesis of chronic renal failure. Development of the chronic renal failure is determined by the progressive affection of the kidney parenchyma. The first signs of renal failure in patients with chronic renal diseases only appear when the functioning parenchyma diminishes to at least 1/4 of its normal size. The functional effects can be categorized as diminished renal reserve, renal insufficiency or failure, and uremia or azotemia. Plasma concentrations of creatinine and urea, which are highly dependent on glomerular filtration, begin a non-linear rise as the glomerular filtration rate diminishes. Changes in creatinine and urea concentrations are minimal early on when the glomerular filtration rate falls below 610 millimeters per minute. Levels increase rapidly and are usually associated with systemic manifestations, with uremia. For substances that are exerted mainly through distal nephron secretion, for example, potassium, adaptation usually produces a normal plasma concentration until advanced failure occurs. Clinical classification of chronic renal failure according to the stages. Latency chronic renal failure, the first stage, intermittent chronic renal failure, progressive or pronounced, and terminal. This is, once again, I emphasize clinical classification because there are other classifications of chronic renal failure. So for the first, we will talk about latent stage of chronic renal failure. It is characterized by presence of nocturia, but nocturia can only be reviewed by special tests for concentrating capacity and by Zimnitsky test. So revise your knowledge about this test from previous semester. So the patient's urine is usually of low specific gravity, and variations of specific gravity are only insignificant. So these patients are characterized by decreased concentration function of kidneys and presence of either hypostenuria. The Clarence test revealed moderate decrease of reabsorption in the renal tubules and glomerular filtration. Insignificantly increased residual nitrogen and creatinine may be detected. So this is the latent stage. Intermittent chronic renal failure is characterized by episodes of marked azotemia. Nocturia is noted, principally due to a failure of concentrate the urine during the night. Lassitude, fatigue, and decreased mental activity often are the first manifestations of this stage. Progressive or pronounced chronic renal failure is characterized by persistent marked azotemia. So the first symptom will be nocturia and hypostenuria. Laboratory studies reveal increased concentration in the blood of various products of protein decomposition. Urea will be increased, creatinine also will be increased, markedly increased. And the last terminal stage of the chronic renal failure is characterized by pronounced clinical picture of uremia and the electrolyte disorders. Urea crystals as a white powder can sometimes be seen on the patient's skin. This is especially noticeable at the orifices of the sweat glands, at the base of the hairs. Strong itching develops and the patient scratches his skin. The skin may appear pallid and yellow-brown. Occasionally, urea from sweat may crystallize on the skin as uremic frost. Decomposition of the urea excreted by mucus of the airways and the mouth to ammonia by the bacteria counts for the specific uremic breath. In serious cases, the smell of uremic breath can be felt by the physician as he approaches the patient's bed. So these are very important symptoms of terminal stage of the chronic renal failure. So itching, urea crystals as uremic frost on the skin, and uremic breath, uremic smell. The nitrogen substances and in the first instance urea are liberated by the gastric mucosa and decomposed to form ammonia salts. These salts irritate the mucosa of the stomach and the intestine to stimulate nausea, vomiting, so uremic gastritis will develop, and diarrhea, uremic colitis. Irritation of the respiratory mucosa causes laryngitis, tracheitis, and bronchitis. Severe stomatic gingivitis may develop. The mucosa becomes affected by ulcers and necrosis. Poisons accumulated in the blood are also liberated by the serous membranes. That is why uremic pericarditis is especially characteristic. It can be revealed by auscultation of the heart using a stethoscope, and specific coarse pericardial friction rub will be heard. Memory and sleep become deranged due to general poisoning. Weakness, dull headache, somnolence, apathy, and deranged vision are characteristic. Metabolic disorders are pronounced. The patient develops cachexia. The liver and bone marrow functions are affected by dystrophy. Toxic uremic anemia develops, which is usually attended by leukocytosis and thrombocytopenia. The tendency to hemorrhages develops due to a decreased blood platelet count. disorders in blood coagulating system, and increased capillary permeability as a result of toxicosis. Hemorrhages of the gastrointestinal tract, urinary tract, uterus, and the nose may develop. Skin hemorrhages also occur, and the body temperature also may be decreased. Later, toxicosis increases, the patient's consciousness becomes dimmed, and uremic coma develops. Periods of stupor alternate with periods of excitation, hallucinations, and noisy, slow breathing, with very deep inspirations, so-called Kussmaul's breathing, or respiration with alternating periods of hyperpnoea and apnoea, which is called chain stokes respiration, occurs less frequently. At the terminal stage, the patient is in deep coma. Muscular cramps occur at times and the patient dies. Diagnosis. Diagnosis of the chronic renal failure is based on progressive azotemia, increased blood creatinine and urea, accompanied by decreased renal filtration and reabsorption, and is a hypostenuria. So glomerular filtration rate is very important parameter which indicates the renal failure development. So glomerular filtration rate is the volume of fluid filtered from the renal glomerular capillaries into the Bowman's capsule per unit time. Glomerular filtration rate can be calculated by measuring any chemical that has a steady level in the blood and is freely filtered by neither reabsorbed nor secreted by the kidneys. The rate therefore measured is the quantity of the substance in the urine that originated from a calculable volume of blood. The glomerular filtration test measures how well kidneys are filtrating a waste called creatinine, which is produced by the muscles. When the kidneys aren't working as well as they should, creatinine builds up in the blood. So there are several formulas for calculating of glomerular filtration rate. They were presented the previous semester, so revise your knowledge how to calculate the glomerular filtration rate. And according to the level of glomerular filtration rate, chronic kidney disease is classified into stages, into 5 stages. The stage number 1, glomerular filtration rate is normal or even elevated, more than 90 milliliter per minute per square meter of the body. Stage 2, glomerular filtration rate between 60-89. Stage 3, between 30-59. Stage 4, between 15 and 29. And the 5th stage, when glomerular filtration rate is less than 15, this is renal failure. The definitive diagnostic tool is renal biopsy, but it is not recommended when ultrasonography indicates that the kidneys are small and fibrotic. And the last our topic for today, pyelonephritis. Etiology. Pyelonephritis arises as a result of ascending infection from intestines and urogenitalia region. The most commonly implicated organisms are from the gastrointestinal tract, such as Escherichia coli, the most common, Klebsiella, Proteus, Enterobacter, Pseudomonas, and Haemophilus influenza. And the second route is hematogenous infection. For example, if patient has chronic tonsillitis or sepsis or some other diseases. Risk factors of pyelonephritis: difficult to run outflow from the kidney, for example, stone in the ureter, twisting of the ureter, stimulates development of pyelonephritis. Nephrolithiasis and neurogenic bladder dysfunction. Neurogenic bladder dysfunction may be associated with urinary tract infections in spinal cord injury, Thebes dorsalis, multiple sclerosis, diabetes mellitus, and in case of some other diseases. Classification of pyelonephritis according to the cause: primary and secondary. Secondary due to urogenital infection or nephrolithiasis or obstructive uropathy and some others. According to the cause, acute and chronic. According to localization, unilateral and bilateral. According to the stage, exacerbation and remission. Clinical picture. For the first, we will talk about acute pyelonephritis. Typical onset is rapid and characterized by chills, fever, lumbar and flank pain, nausea and vomiting. Symptoms of lower urinary tract infection, for example, frequency, dysuria, occur in about 1/3 of patients. So the main complaint will be pain in lumbar region or in flank pain. If abdominal rigidity is absent or slight, a tender enlarged kidney may sometimes be palpable. Costovertebral tenderness and positive Pasternatsky symptoms. So costovertebral test will be positive, and it will be bilateral in case of bilateral pyelonephritis and unilateral in case of unilateral pyelonephritis. Unilateral pyelonephritis is more common. Chronic pyelonephritis. Symptoms of exacerbation may be similar to the clinical picture of acute pyelonephritis, but symptoms and signs in chronic pyelonephritis are often vague and inconsistent. There are several forms of chronic pyelonephritis according to leading syndrome. May be hypertensive chronic pyelonephritis, nephrotic, septic, hematuric, anemic, and latency. We will start from nephrotic form of chronic pyelonephritis. This form corresponds to nephritic syndrome characterized by edema, urinary syndrome, and comparatively rapid course. So the next clinical form, hypertensive. This form is characterized by arterial hypertension syndrome and insignificant changes in the urine. The septic form is characterized by high fever, bacteremia, and high leukocytosis, and severe pain in lumbar region. Hematuric form is detected by persistent macro or microhematuria. The next, anemic form, is characterized by anemia due to decrease of erythropoietin production and hematuria. The next, the latent form of the disease, which is not manifested by edema or pronounced hypertension, and the changes in urine are only insignificant. Laboratory and instrumental findings in case of pyelonephritis. So for the first, we need urinalysis. In urinalysis, we may detect bacteriuria, the presence of bacteria in urine, leukocyturia, presence of leukocytes, of increased level of leukocytes in urine, proteinuria, hematuria, and cylindruria. So, from the previous semester, you must revise your knowledge about urinalysis, about normal content of urinalysis, normal rate of leukocytes, bacteria, protein, and so on. Urine pH may be alkaline because of urea splitting organisms, and we need bacteriological study of urine in order to detect the causative bacteria and to determine the bacterial sensitivity to antibiotics. Next, we may need ultrasound, abdominal and renal ultrasound. We may detect renal scarring, renal atrophy, renal cortical thinning, compensatory hypertrophy of residual normal tissue, which may mimic a mass lesion, callitol and clubbing, secondary to retraction of the papilla from overlying scar, thickening and dilatation of the calculate system, overall renal asymmetry, and we may detect stones in pelvis. Then we may need intravenosus or retrograde pyelography, which can reveal deformation of the renal pelvis and urinary obstruction as a cause of pyelonephritis.